So hello everyone. Our today's lecture is Analytical Study Designs as part of the basic course in biomedical research being organized under the aegis of Institute Research Committee of Dr. B.R. Ambedkar State Institute of Medical Sciences, that is AIMS Mohali. Myself, Dr. Japleen Kaur, and I'm an assistant professor in the Department of Obstetrics and Gynaecology. So just a brief outline, we'll talk about the various study designs and what are the observational analytical studies, which are the main subject of today's lecture, like the cohort study, case control study, analytical cross-sectional studies. Then we'll compare the cohort and the case control studies for their strengths and limitations, and we'll discuss a few sample questions so that we know what all you have understood from this lecture. So this slide is maybe a little confusing, but it's very, very important considering that sometimes the classification of study designs is done differently by different researchers. So in the last lecture, you must have seen this flowchart. That is, the epidemiological studies are being divided into descriptive and analytical. The descriptive are further divided into case report, case series, cross-sectional service, and lithological based on the unit of observation being individual or population. And the main difference between descriptive and analytical is that in descriptive, we are simply describing a population in terms of percentages, the variables, proportions, but we are not really correlating or associating any exposure with the outcomes. In analytical studies, this is exactly what we do. We try to make associations between certain risk factors or exposures to their outcomes, or which may be diseases in our healthcare setting. So the analytical can further be of two types, like observational or experimental and interventional. Now, the observational analytical studies are cohort studies, case control studies, and sometimes even the cross-sectional studies can be analytical. And the experimental or interventional are the RCTs or clinical trials. The main difference between these two is whether the investigator has assigned the exposure or not. So the other way of classifying is starting with whether the investigator has assigned the exposure or not. If yes, then it is called an experimental study. And if not, then it is called an observational study, right? So the risk factor is somehow present, like a hypertension or diabetes, but it is not the researcher or the investigator who has given that exposure. So under observational study, if there is a comparison group, it is called an analytical study because we can make associations and correlations only if we have a comparison group which does not have that exposure. But if it is just an observational study, all cases of hypertension are being studied for their development of CAD or not, then it becomes, and there is no comparison group like non-hypertensive patients suppose have not been included, then it becomes a descriptive study. Now, under an observational analytical study, how do we classify the study designs? That is based on the direction of the study. Whether we are moving from exposure to outcome, like the exposure, hypertension is there, we are following up those patients for development of diseases, then it's a cohort study. But if we are moving from the outcome to the exposure, like we have some cases who already have coronary artery disease, and we have some cases who do not have coronary artery disease, and we look into their background to see whether they had hypertension or diabetes or not. Like we are moving from outcome to exposure, then it becomes a case control study. And sometimes cross-sectional studies, exposures and outcomes have occurred at the same time. But if we take an internal or external comparison groups and we are able to make some sort of associations or correlations, then we can even call these cross-sectional studies as analytical studies. Right? So two things to remember are, did the investigator assign the exposures or not? And was there a comparison group or not? These two things can help you decide what is the study design. And you must remember, if we see these two flowcharts also, the experimental studies are always analytical because here, whether the investigator has assigned exposure there will always be a comparison group. When we randomize at least in 2 groups, right? So we are always trying to make some associations or comparisons in an experimental study. So they are all analytical by way of their design. So coming to the subject of today's lecture, that is the observational analytical studies. They can be either descriptive. Observational studies can either be descriptive or analytical. So like we read, that basically under analytical studies, we can attempt to quantify a relationship or association between the variables like the risk factor and a disease. But they are called observational analytical because we have not assigned the exposure. If we were assigning the exposure, then we call them experimental studies. And there is a presence of a comparison group, right? Exposure is happening by itself, but we are following them up. We have a comparison group so that we can make some associations and correlations, right? Now coming to the first type of observational analytical study, that is a cohort study. So the origin of the word cohort is from the Roman army, where a group of 300 to 600 men was called a cohort. How we choose a cohort? Basically, they share a common characteristic. Suppose all students of one class. Suppose all senior residents of B.R. Ambedkar Institute, right? So we move from the exposure towards the outcome. This is the important thing to remember when we are talking about a cohort study. Whether, okay, we'll go to the types of cohort studies further, right? Whether it is a prospective or a retrospective or an ambispective, the direction of study remains from exposure to outcome, even if we are doing it in the past or for past subjects. So the first is prospective, right? Exposure may or may not have happened at the time start of study. We may be taking up cases who are exposed also later, or we may already take subjects who are exposed to a particular risk factor, but outcome has definitely not occurred in them at the start of your study. Rather, all those having the outcome under consideration are excluded to give an at-risk population. Okay? While in a retrospective study, the exposure and outcome have happened in the past, but when you are selecting the cohort, you are selecting it based on the exposure. So even if you open the case records of patients who had hypertension and you want to see whether they went on to develop coronary artery disease, you will search the case records based on the presence or absence of hypertension, right? Not coronary artery disease. So this is where it is different from a case control study. For case control study, if you had to do a case control study for patients developing coronary artery disease and hypertension, you would have selected cases based upon the presence of coronary artery disease, right? So even if it is done from case records, it can still be a cohort study in which we are following up from the risk factor to the outcome. And it is called ambidirectional ambispective, in which we have taken some subjects from the case records and some we are prospectively taking in real time, right? So again, what is important to remember is that the selection is based upon the exposure, right? This is a brief summary of what we were talking about till now. I think it is pretty easy to understand. So if we are sitting here, already exposed and unexposed population is there, they have already developed some. We want to see whether they have developed the skin rash or not. We know that they may have already developed it, but we start from here. We look at the exposed and unexposed, and then we follow them up in the past only, in their case records only. But it is called a prospective, in which we start taking up patients who have been exposed to a particular risk factor, some who have not been exposed, and then we follow them up to see, for example, all the HPV patients who have HPV in their cervical smears, or the patients who do not have, and then we went on to see whether they develop cancer or not. And if we look at some patients from case records, some we follow prospectively, then we call it an ambispective study. Now, these are the basic elements of a cohort study. We select the study population, which may be general or subset. We gather some baseline information like whether they have been exposed to the risk factor, or they can be exposed to this risk factor, but we must exclude those with the disease. The choice of comparison group, it can be internal, unexposed persons in the same population, for example, hypertensive versus non-hypertensive, or external, like we are comparing all the workers in a factory who developed an aniline dye factory who went on to develop bladder cancer. Now, all those within the factory are exposed. So here we take external population as the comparison group. And we follow them up longitudinally. What is important is that we must have standard guidelines for diagnosis of outcomes so that we don't, have any ambiguity in confirming whether they develop the disease or not. And what is the measure of correlation that we get from a cohort study? That is the relative risk. So this is an important thing, how to make a 2x2 table. So this is a 2x2 table, diseased, not diseased in the columns, exposed, not exposed in the rows. So this is A is basically all those who were exposed and got the disease is A. All those exposed but did not get the disease is B. All those not exposed and yet got the disease is C. All those not exposed and did not get the disease is D. So how we calculate the relative risk is incidence of diseased in the exposed, that is A, divided by incidence of all the diseased who are not exposed. So A over A plus B, this A over A plus B. So all those who got the disease out of those total that were exposed is the incidence in exposed. And incidence in not exposed is C divided by C plus D, right? So interpreting this relative risk, if it is equal to 1, that is the incident in exposed and not exposed is similar, then we can say that the exposure is not associated with disease. But if it is more than 1, we can say it is positively associated with disease. Less than 1, it may seem that exposure is negatively associated with disease, so it may be a protective factor. Now coming to a case control study, here again the important thing to remember is that the outcome is already present, right? In the cases it is present and we are choosing the cases on basis of the outcome, and controls, the outcome is absent. Otherwise they are a related population or sort of matched for other things. So the direction is from outcome to exposure. It is a reverse kind of a direction. Again, how we select the cases, clear definition of the outcome, standard guidelines, right? Then the sources can be hospital-based or population-based. We select the controls from mostly same source population, but independent of their exposure status. We only see that they don't have the disease, whether or not they have the exposure is not part of selection of controls. And collecting data based on exposure, again here we must be very careful how we are collecting data about their risk factors or exposures. It should be as objective, accurate and precise as possible. And yes, there may be some recall bias since the cases may remember their exposures more clearly instead of compared from the controls. And the measure of association that we get from a case control study is basically the odds ratio. Again, the 2x2 table, but here, because we have moved from the outcomes towards the risk factors, we can't get incidence. The disease was already there when we started the study. So, but we can only make an association based upon a probability. A probability that the case that we have was exposed, right? So, A over A plus C. Then probability that the case was not exposed, C over A plus C. Odds that the control was exposed, right? Not exposed, still got the disease. Not the control that is not diseased was exposed or not. And odds over the probability that the control was not exposed is D over B plus D. So the odds that the case was exposed to the odds that the control was exposed is A by C plus B by D, so AD over BC. So if you make the 2 by 2 table like this, A into D divided by B into C. Again, how we interpret the odds ratio, we can say if it is 1, the odds of exposure being among the cases and controls are probably the same. So association is unlikely. We can't say there is no association, we can say it is unlikely. And if it is more than 1, odds that the exposure among cases was higher, probably, so likely to be have a positive association. And less than 1 means odds are probably lower in the cases, so likely a negative association of the exposure with the outcome. Briefly about analytical cross-sectional studies. So mostly cross-sectional studies are descriptive. We describe the prevalence of a disease, the proportion of affected or not, or the demographic characteristics. So they mostly tell about this prevalence traits such as smoking behavior, people's attitude, knowledge, etc. Whereas analytical studies, they aim to assess the association. So data on the prevalence of both exposure and the health outcome are obtained for the purpose of comparing the health outcome differences between the exposed and unexposed, then it is, and at the same period of time, not a longitudinal follow-up or case control. So here it can be an analytical cross-sectional study. Now comparing these important two study designs, cohort and case control, for their strengths and weaknesses. Cohort study can give you incidence. You can study multiple outcomes for one exposure. You started from exposure, so you can see what all that patient can develop from that one risk factor. And there is a clarity of temporal association because you know that when you chose those patients for their exposure, they had not developed the disease. So if they have developed later on, there is a temporal association. And it is good to study the rare exposures, right? But weakness is that it is expensive, time consuming, you need a long follow-up. Some diseases may take a long time to develop. So it's not good for rare diseases or those with a long latency. For example, AIDS may develop after 10 years of HIV. So sometimes if you keep on following those patients for 10, 15 years, it may not always be possible and it becomes expensive and time consuming. Then again, keeping track of those patients for 10 years, they may move out, they may just lose interest. So there is a high risk of an attrition bias, that is a failure to follow. So coming to case control study, some of the weaknesses of the cohort study are covered in the case control study. It's relatively quick to conduct, inexpensive. You already have the disease, so you may require a fewer subjects only. And it is good for rare diseases. You fatapat catch on hold of the disease part and then you go back. And you can study multiple exposures or risk factors for one outcome. Weakness again being that it suffers from a recall bias. The subject, the case who has the disease may be able to give you a better recall of the risk factor, whereas the control may not really be very sure whether he was exposed to the risk factor or not since he didn't get any disease, so he may not remember that much. Then again, selecting an appropriate comparison group is challenging because we try to match the controls as much to the cases as possible so that there are not too many differences. Like we wouldn't really want to compare the Americans to the Indians directly because there are a lot of other factors involved. And we do not get incidence, which is the major weakness. So we cannot calculate the real relative risks, although the odds ratios can give us some hint about the association. So coming to the sample questions, just to know whether we have understood or not, the entire population of a given community is screened and all those judged as being free of the colon cancer are questioned extensively about their diet. These people are then followed up for several years to see whether their eating habits will predict their risk of developing colon cancer. Identify the study design, right? So just think, don't get confused with this free of colon cancer. Are we starting with outcome? No. We are studying people for their eating habits. And we have very clearly, excluded those who had already colon cancer developed. So we are eliminating these people to give an at-risk population. Then eating habits is our exposure that we are studying, and we are following them up for several years. So the design is very longitudinal. to see whether they develop the colon cancer or not, that is, they develop the outcome or not. So we are moving from exposure to outcome. Now, which is that study design out of these? Case control, clinical, cross-sectional, cohort. Now you may get confused with clinical, but remember, here you have not assigned the risk factor. Their eating habits is something that they are just doing. You have not told them, ye aadhe log ye khayenge, aadhe log ye khayenge. You've not done that. So it is not a clinical trial. The investigator has not assigned the exposure, but it is a longitudinal follow-up moving from exposure to outcome. So it is a cohort study, right? It is a cohort study, right? Now, which of these is false regarding a case control study? The two important study designs that we have studied here, appropriate for study of rare outcomes, right? Because we are starting with outcomes, we can study the rare outcomes in the case control study. So this is correct. More time consuming than a cohort study. No, because there is not much of a longitudinal follow-up. We see the cases, we study their background, we question them about their risk factors, or we see their case records for the risk factors. So no, it is not very time consuming. Multiple exposures can be examined. Yes, we already have an outcome. From the case record, we can, or from the questionnaire, we can ask about any number of exposures or risk factors. So yes, multiple exposures can be studied. Relatively expensive compared to cohort? No, like we decided that in this, we are really not following up patients for years. We are not seeing the incidence. So they are not relatively expensive. So this is wrong. So the correct is, which of this is false? The question, must read the question whether they have asked true or false. So which of these is false? 2 and 4 are false. So C is the right answer. Now, this kind of question you may get where you need to calculate either relative risk or odds ratio. So first identify the study design, then make a 2 by 2 table, and then according to relative risk or odds ratio, you give the calculation. So here, a prospective cohort, it is written clearly that it was a prospective cohort, so you know that you have to calculate a relative risk. Yeah, the question also says relative risk, prospective cohort study. So now the important thing comes down to making the 2 by 2 table. So it was conducted to determine the association between coffee consumption and risk of pancreatitis amongst 10,000 healthy participants. 3,500 participants consumed coffee. So basically, the 2 by 2 table that you have to make is, I'm having a little trouble. The 2 by 2 table that you make, you should remember that your outcomes are in the columns, whereas your exposures are in the rows. And this is coffee, coffee, no coffee, then pancreatitis, no pancreatitis, right? So this was your A, B, C, and D. So all out of 3,500 patients total consumed coffee. So this is the total of those who, the total here is, the total here is 3,500. Okay. I think I'll skip the pen. Okay. So, yeah, so here we know that all those who consume coffee are 3,500, right? And 6,500 did not. Even if they had not given this to you, you would have probably been able to subtract it from 10,000 and got this number. After 10 years of follow-up, 85 developed, in the coffee consumption group, developed pancreatitis. So this is what you get, 85. Whereas amongst the non-coffee who developed pancreatitis was 130, right? So the relative risk is basically the incidence of disease out of those who were consuming coffee, that is exposed. So 85 divided by 3500 was the incidence amongst disease. Incidence amongst not exposed, sorry, incidence among exposed, incidence of the disease among those that were not exposed. So 130 divided by 6500. If you will calculate it, you will get the answer as 1.21, right? So this is basically all for today. Thank you so much, and you can ask questions in our as comments in our YouTube link. Thank you.